on the quality and context of surgical margins in bone sarcoma. What aids do we need to achieve these margins? Besides our wits, we need to think about how best we can achieve these margins and what tools we need. 3D navigation entails drawing a tumor and a resection margin, often on a CT or MRI scan. You match this with a scan taken on the patient on the operating table, and you can then calibrate a pointer or a chisel or even a saw, and by that way better find your way inside the patient and avoid entering the tumor when you make your cuts. So this is in widespread use both in the spine and the pelvis, also here in Oslo. And an isolated comparative series of periacetabular chondrosarcoma showed that using it was related to less intralesional margins in bone and less local recurrence, correlating also, in fact, with improved survival for those that were navigated. It did not, however, appear to reduce contaminated margins in the soft tissues or eliminate local recurrence as a concept. Cutting blocks. These are 3D printed bits of plastic designed to fit perfectly on the bone of your patient. It has a saw guide, and this you can't see my finger obviously, and this slot here, which means that you can beforehand plan where you're going to cut and follow this track. So in our experience, this is very positive, but its effect on margin hasn't been properly studied. I think still that the best guide to surgery are dedicated to a group of tumor radiologists, but technology is giving us a helping hand. To assess morbidity or function, we need also to be able to measure it in some way and report it. So there are two main ways to measure that we use in the sarcoma community, but both are pretty coarse. One is called the TEST score, and the other is the MSTS score. They score various parts of patient function and acceptability and give a score out of 100 and out of 30, but report generally in a percentage of 100. So for healthy men in the UK and Australia, a cohort of men report tests of 95. While for men in their 70s, they report a test of 76. Women in their 70s report 88. The first decision to be made is whether or not you have to amputate or whether you can retain the limb. Technically, the limb, together with the hemipelvis, can be amputated with what we call a hemipelvectomy. This is a dramatic and life-changing event, of course, and the decision must be made individually and in the setting of a sarcoma team. As a rule of thumb, if two or more critical structures, that is the hip joint, the sacroiliac joint, the external iliac or femoral vessels, or the femoral nerve, sciatic nerve, are involved by tumor extension, then you need to have an open discussion of whether amputation might be the most appropriate for your patient. At group levels, both of these options are safe oncologically, but at an individual level, you need to guide patients more specifically. So a combined international effort documented the functional outcome and pain for 78 patients treated by hemipelvectomy. So you can see that about half of them use crutches in the green, which is there, but though in fact nearly 10% manage with a cane in the purple, and 30% use a wheelchair or walker, which is these, but 5% in fact in the blue are bedridden. Further down, we can see for pain that a significant portion of patients also suffer from long-term severe pain in the yellow. And although the younger patients have better function, they also have more pain. Moving on to what we call a type 1 partial or total, is removing the ilium bone. It's fairly controversial that partial resections that maintain the pelvic ring, such as this case, they do not need reconstruction. For those, however, with a complete resection, if you cut down here and there's a gap in the middle, type 1 resection without reconstruction, there is an accepted truth that poor function follows. Again, studied by the Birmingham group, a test score for 7 patients without reconstruction has 53, as compared to those with a resection they have, or those with a partial resection, sorry, with a retained ring have a test score of 76. And for those that have a complete resection but with a reconstruction, they have a score of 72. So the fibula, moving on, there. The avascular fibula is a method where you remove a section of the fibular bone from the leg and insert it as a strut between the pelvis and the acetabulum or the sacrum or wherever you can. It's relatively easy technically, and it has pretty limited donor morbidity from the leg, but it's not without its complications. It can dislocate both into the spinal canal and into the hip, but it does heal relatively predictably. I thought I had figured out type 1 resections, but I found this Canadian report from just last year. In fact, and they have a series of type 1 complete resections without any reconstruction that they've followed for 10 years. And they argue for this that via reduced operating time, less blood loss, less perioperative complications, shorter hospital stay, and improved function. And they, in fact, report an average test of 76. So they're at the level of the 70-year-old men. They described that the remaining hip and ilium gradually collapses towards the pelvis and iliosacral areas, forming a pseudoarthrosis. So who knows? With regards to type 3 resections, removing the pubis or the ischium bone, there is little literature really, but Hillman et al. Found that these patients without reconstruction had the lowest rate of complications and highest function of all pelvic resections, underlining a conservative approach. They use the MSTS score but report 79%. There is, however, some morbidity related to herniation, but that can generally pretty well tolerated and can be countered by the use of a net, although with somewhat more complications. A hip transposition is the name we imply when we move the hip up onto the remaining pelvis or sacrum, either in its native form like here, or with an internal prosthesis as here. And often you envelope this in a Gore-Tex net that you sew together to create an artificial pocket joint in the area. The advantage of this are low cost, less complications, and improved function, though with the cost of leg length discrepancy. The leg is shorter, it starts further up. So Fujiwara, again from Birmingham, studied this technique for pelvic Ewing sarcoma and found that they had significantly better pain, emotional acceptance, better walking distance, and overall scores compared to other methods of reconstruction, primarily driven by high rates of infection in the other group where they try to reconstruct. But comparing it to those other reconstructions without complications, they were the same. So in many parts of the world, there's been a tradition also to use what's called an allograft. This is in particular in Bologna, amongst others. So this is primarily for what we call type 2 and related surgery, which is areas around the hip joint. So an allograft is a hemipelvis from a cadaver. It's often matched to the existing patient with regards to size and attached with plates and screws that you can see here. So the articular cartilage, the joint, doesn't deal with this very well, and often you have to use a prosthesis as well, and this means it's called an allograft composite. Living outside the body, the bone becomes weaker and is prone to fracture, and getting it to heal towards the native bone can be quite problematic, but is achievable. The addition of all this metal makes it prone to complications. So these have to be removed in about 25 to 40% of cases, mostly due to infection and mechanical problems. The upside is low cost, retained anatomy, and function as per an MSTS score of 72%. In a similar manner, though used much less often, is something called an autograft. So you take the bone out of the patient, you treat it outside with radiotherapy, heat, or liquid nitrogen, and then you put it back in, much in the same manner as you do with an allograft. Again, often having to combine the joint line with a prosthesis. So these have the advantage of a perfect fit. It's always going to fit because it's the same. And low cost, of course, but they have the same complication profiles as the allografts. So many types of prosthetic solutions have been used in standardized and custom forms, but most have been discontinued due to high rates of complications. So we're currently using what's called a Lumic pedestal cup for the prefabricated solution. Prefabricated meaning you have it in the cupboard, it's ready to use, and you can generally, it's also modular, so you can adjust it to the situation that you're in. So we contributed patients to a Dutch series reporting 47 cases, which showed a mean MSTS score of 70%, but complications, in fact, in nearly 70%. A Turkish group described them with a bit more follow-up and said that at 5 years, 80% still had their implant, but they had reoperated about 30%. This is the last type of treatment, an example of a 3D printing plan, which entails drawing a segment of bone that you want to remove, containing both the tumor and the margin, and planning the bone cuts in 3 dimensions. You can then use that to create cutting blocks that we've looked like and a specific 3D printed pelvic prosthesis that matches the anatomy. So our experience for this so far is very positive. We've done 9 cases. The pre-op planning and production takes more than 6 weeks. It gives good precision for both tumor resection and well-fitted implants with normalized hip rotation and reduced operation time. It is, of course, very costly. We've had 1 patient with a local recurrence and 2 with infections, but both have retained their implants. So these are our cases. In conclusion, the first case with an osteosarcoma, it looks like a partial type 1 resection, but we also had to remove part of the sacrum and also tissue up along the spine. So she got both a fibula and rods and screws. She had an infection, and she's unfortunately also had a local recurrence for which she's now had proton photon therapy. Case 2 was the Ewing sarcoma. She had a 3D printed prosthesis. She had an infection. She still has her prosthesis, but again, she also now has a recurrence and is not doing so well. The third case, all these cases had R0 margins. Third case, the man, he has also a 3D printed prosthesis, which was doing really well, but there's lots of ossifications, which means his hip is growing into his pelvis, and so he is pain-free, but doesn't have this fantastic movement that we're going to talk about. And this is the reality of pelvic bone tumor management. Thank you so much for your time.
Thank you. Now we open up for questions. We can have dumb questions,
Yep.
smart questions, and if anyone wants to ask the question in Norwegian, we can do that as well. I think everybody wonders, how is your hip after 45 minutes of standing?
It's a bit sore.
Yeah, okay. Yeah. Does anyone have any questions?
This is my dad.
Yes, I don't need a.
Okay.
You said early on, you mentioned, I believe, increasing diversity of symptoms. Are you conscious of where in your presentation that was? Because I was waiting to hear more about the increasing diversity of symptoms, but I never got it.
Okay. Is it here?
Could it be?
Yeah, so the symptoms of these patients isn't actually studied that well. And when it's studied, it's generally studied with hindsight. So you go back to the journal and you notice, okay, the doctor writes that they have pain. But obviously that is much less accurate than actually noticing it as you're doing it, and what we call prospective registration. So it hasn't been a very highlighted area. With regards to the diversity of how many different things, it would be interesting to see what was the initial diagnosis of the first person that met you, the first GP or a physio or a healer or whoever it is that sees you first. What is it they first thought it was? I haven't seen any research on that. But these are very aggressive tumors in part, and you would think maybe that more often they would present by pressing on important nerves or blood vessels or even the bladder. But in fact, that occurs pretty infrequently. Occasionally, these progress so much that they come into the hospital, you know, with the whole limb being threatened, that the limb isn't getting enough blood and that sort of thing. But that's very, very seldom, luckily. So it mostly is the simple things of pain, but the type of pain is just very difficult to characterize and define.
Must be a tough challenge.
It's difficult because patients think that we're able to differentiate all this pain, and sometimes I think we as surgeons think that we're able to as well, but for things like the shoulder and the knee, it has been investigated, and it shows that time and time again, whenever we think we're right, we're not. So in fact, it's to sort of make decisions on the basis of that can sometimes be very, very difficult. The body is complex.
Does the committee have any questions?
Excellent presentation of everything to do with the pelvis, which was very thorough. So you talked about we work in a numbers game. You know, we're a population-based speciality, and you said there are about 7 pelvic primary sarcomas a year in Norway.
Yeah.
What do you think the minimum number of operations you should do on a pelvis is?
We luckily do more numbers than this, amongst others with our work with Kjersti. So we work together with them on the very locally advanced rectal carcinomas, and we do quite similar operations for that. I think ideally we should be doing more than this. Norway is a small country. You have to, in these 7 also, we're 4 orthopedic surgeons. We always have one name at the start of this surgery who has the responsibility, but we're all 4 doing this surgery. You could easily make the case that for Scandinavia, for example, this should be centralized to one center. And although cooperation in Scandinavia is very widespread, we're not there yet at all. But I think definitely there are forces who have those thoughts. And I think if you could create a structure of you get some, you lose some, it would be, you could easily move patients in Scandinavia for this type of surgery. And I think definitely it should be probably closer to 50 than to 7.
How is the situation in Birmingham, in UK?
We'll talk about it later, I'm sure, but we look after 22 million people, so we do about 50 a year. But one of the points I wanted to come back to about centralisation, which I think is fundamentally important, is that you can specialise within a team as well. So I think it's good to try to get a situation where you have 1 or 2 people that say, we're going to do all the pelvises, because at least you get 1 every other month then. And there are 4 units in Norway.
There's 4 units, but the bone sarcoma only happens at 2, and 80% of that is here. Yeah.
So we talked about that you've got sacral lesions, P1, P2, P3. You elegantly show that they have different ways of treating them. Then you've got the complexity of Ewing's and whether you should give preoperative radiotherapy or not, or chemotherapy in response. So actually, when you look at the variables, you're probably only seeing less than 1 of each per year.
Yeah.
So 1 chondro P1 or 1, and they're all treated very differently. So it's important that as a group, whether that be just within Norway or within Scandinavia, you try to centralise that.
Yeah, I think you're right, and I think we us, even just amongst us 4, we need to sort of have a discussion of, are we all to be doing all the same stuff? Should we all be doing the spinal and the pelvic, or should we subspecialize? And the problem, pros and cons of that, obviously, is that you're much more vulnerable, but there are clear advantages to it. We have tried to retain a bit of everyone should be able to do everything thought, but I think quite naturally sometimes some people take more responsibility for one type of a situation and they gain a bit more experience. for example, the 3D printing, we by necessity can't all communicate with the company, so we've been 2 people to do that. And that also entails a bit more responsibility for those operations. But that's small scale stuff. We really should be talking larger numbers. And I think if we talk then for all of Scandinavia, which has a population of 24 million or something like that, then we could really talk numbers.
Yes, I agree with the excellent trial lecture.
Thank you.
This slide here, tell us a little bit about UPS,
Yes.
other, and do you suspect them by imaging, and or are they unsuspected?
Yeah, so UPS is the sort of the others, the unspecified. So this is the diagnosis of exclusion. So it's called for undifferentiated pleomorphic sarcoma. They've changed the name every 8 years or something because they don't understand what it is. But the situation isn't the same. If it's not any of the others and some other very rare also primary bone tumors, then this is it. Radiologically, it can mimic both of them really, and so it has slightly different profile with regards to age, being more common again in the elderly. But imaging-wise, you can't differentiate these from an osteosarcoma or a Ewing sarcoma.
And another question, the slide with the pain, like your father asked about, you had incidental findings.
Yes.
Can you tell us a little bit in what imaging modalities, and is there better prognosis in these cases?
I've not actually studied the prognosis, but I should do. These are mostly discovered on MRIs and CTs of the hip or type prostate type pictures where the hip or acetabulum is in the picture but not centered along these. You can always say, I actually think that these numbers are higher than what they are, because although people have pain, what is the cause of pain? This can take us into this whole discussion about enchondromas and this sort of thing. Registering pain afterwards is so inappropriate, and what is actually the cause of pain. But I think generally these tumors are generally at a reasonably early stage, but like this one, you see it's in the pelvis, it's got a soft tissue component of a certain size, so it's not only that. So it's interesting, sometimes you can have a fair bit of cortical destruction and a soft tissue component on the one side that has no pain, and then you're sitting in a clinic talking to someone who has a little tumor inside their bone marrow that isn't growing, and you're trying to explain to them that their pain isn't coming from this tumor that they can see on the screen. Seeing something on a picture is you definitely blame the thing that you can see first, but most pain isn't visible on a scan. Most pain is a misbalance between muscles and tendons that's not visible on MRI. So we also have this system where we do scans and talk to the patients and go for treatment, but the human body is just more complex than that.
So I want to move on to that. You talked very elegantly about new forms of treatment, so protons and radiotherapy, perhaps being used in a new way. And I was very impressed by your drawing it back to history and the lessons that we learn from history, or sometimes don't learn from history.
Yes, indeed. Yeah.
So how do we work out as a group of clinicians whether we should be giving radiotherapy or proton therapy to osteosarcoma, say, when we have oncologists who have got a new toy that they want to use, surgeons who want to do operations and don't want to not do operations, and oncologists who are always tinkering with new chemotherapies. So how do we work out as a community which is the best way forward when it's non-traditional treatment?
I think the sense of cooperation within the sarcoma community internationally, I think, is probably quite exceptional compared to a lot of fields, but it still has a long way to go. And I think we've all sort of resigned a little bit. We're all doing our best for the patient, and some people are doing this and some people are doing that, and we have arguments on both our sides. But the reality of this is that we can agree to do one thing or the other and study it properly, rather than do up the numbers afterwards and see what happened. So I think, for example, for us in Europe to agree that in these amount of centers, what we're going to do for pelvic is just do definitive radiotherapy by this and this scheme. That's it. It will give us a much easier comparison, and another center can do just surgery, or we need to have clean series and we need to compare them. And I'm obviously just pretty junior to the game, but we need people to come in with, you know, a sort of charismatic authority that can inspire people to say that I want to be a part of this and I want to try to find a solution and an answer, rather than just go to work and do what's expected of me and do what we usually do. We really need to sort of up our game a bit, and we can uncover a lot of truths about this, but we need to be organized and we need to get numbers and we need to do it properly.
Are there any more questions? No. Then we'll take a short break. The committee has a difficult task to decide if you have passed this trial lecture. So they will come back in some minutes and will announce if you have passed the trial lecture and can continue the day.
Perfect.
Okay?
Yeah.
Thank you so much.
So I'll take all the boxes. I will. You have a really good guy in your surgical European team. Yeah.
Now we're actually finished with the short meeting. So, Lee Jace wants to announce.
So as you can see, after our extensive deliberations, the committee has unfortunately decided that you have to continue with the rest of the day. Congratulations on an excellent lecture.
So now we're going to have a longer break, and the doctoral defense starts at 12:15, and then we'll meet back here again. Okay, thank you so much.